Thank you, everyone. We're going to give it just a moment here as people are logging in. All right. Well, thank you everyone for joining us today for Trauma Universal Precautions and ACEs with Dr. Andrés Sciolla. I want to give everyone a reminder that this is worth 1 CME. And you'll get an email tomorrow with a survey link. Once you complete that, the certificate will be emailed to you. And I also want to ask everyone, if you have any questions throughout the event, throughout the lecture, please drop them into the chat function. We're going to be using that today instead of the Q&A. We'll use the chat function so that everyone can see the questions and that we can all address them together. And without further ado, I would like to introduce to you Dr. Andrés Sciolla. He is a professor emeritus of psychiatry at the University of California at Davis. His expertise is in trauma-informed care, which originates from a career focused on mental health services for underserved and disadvantaged individuals. During this time, Dr. Sciolla has taught about trauma-informed care to interprofessional teams, practicing physicians, and medical trainees. He's currently conducting research on the psychosocial determinants of resilience in medical, nursing, and veterinary medicine students. So with that, I'll ask Dr. Sciolla to take it away.
Thank you very much, Brandon. And thank you to the Sierra Sacramento Valley Medical Society for inviting me. And thank you very much, all of you, for being with me this evening, joining me, and what I hope would be very practical, applicable presentation geared to everyone, every physician or any actually clinician who sees patients. Even though I'm a psychiatrist, I really appreciate this opportunity to share some of my experience and ideas to make this relevant to a general practitioner and also specialists. So this, as you can see from the subtitle, the bottom line of this presentation is that you don't need to know to respond in a trauma-informed way. That's the gist of this presentation. And I will tell you now my disclosure. I want to make sure that you guys can see. Hang on a second. I take it that you are now seeing my disclosure. And actually, I'm going to, if you allow me, I will go back to the first slide. I don't think you saw this. And so the disclosure is that the content of my presentation, I have nothing to disclose, basically. Now, this figure, this painting, wants to illustrate the idea behind a complex phenomenon of trepidation on the part of physician and healthcare providers of not anchoring into trauma in general, and perhaps particularly some experiences that are surrounded by stigma, shame, and taboo in our society. So this is a painting of Pandora, who is reluctant to open the Pandora's box, her box. So the idea is to empower you and give you tools to open that box only when you need, and minimize unwanted disclosures, if you will. On the other hand, this is important that we're talking about not opening, but eventually also prompting you to think about how to and when to open that box, because the risk of never opening this Pandora's box of trauma is that symptoms and problems keep recurring and keep circling back. And that can lead to all sorts of problems, including for our own practice, frustrations, and all kinds of other problems. including, of course, for patients. So the learning objectives and previewing what's going to happen, we're going to divide this presentation into three portions, addressing each one of the learning objectives. And between 2 and 3, we'll take a short, depending on the time, maybe 5 or 10 minutes of reactions to probe how you guys are processing all the information. And so I want to ask you to put comments and questions and reactions in the chat box. So first, we're going to explain the trauma and universal precautions idea, then go to be able to articulate brief patient-centered communication skills to elicit a history of ACEs that minimize retraumatization and unintended disclosures. And number 3, identify at least one current policy or practice in your workplace to that you can think of modifying to minimize the risk of re-traumatization. So the first learning objective is to understand the trauma universal precautions concept that was put forward first by Sheila Raja and her collaborators in this represented in this pyramid. So she conducted a review of trauma-informed care and the various skills and attitudes that go with that practice. And she represented screening, that is to say, ask about trauma as the pinnacle of this pyramid. And the size of it represents the frequency with which clinicians can engage in this activity. So at the bottom of this is patient-centered communication skills, then understanding the health effects of trauma. So two basic, if you will, sets of skills and knowledge, then the collaboration, understanding your professional role, because you're going to be able to refer patients, for example, for therapy. Then, very importantly, is the understanding our own history of trauma and adversities. And last, the least frequently, is screening. So in a more detailed view to this, she called that the 3 superior steps of the pyramid trauma-specific care, which are the strategies used when a patient's trauma exposure history is known, as opposed to trauma universal precautions, which are the knowledge, skills, and attitudes that increase patient engagement, very importantly, and some health outcomes without requiring screening or knowledge of exposure. That is to say, what I do if I assume that every patient that comes to my clinic, my hospital, my health center may have been exposed to trauma. So the first step in this pyramid is nothing new, is good old patient or person-centered care. So here's an old quote from William Osler: "The good physician treats the disease. The great physician treats the patient who has the disease." So I think we all know this quote, and we all know, so take this as a quick review of patient-centered care. And this is just one model of patient-centered care. There are a great variety of them. And so just to go over in this particular model, the elements of patient-centered care. And quickly, and I will make some comments to highlight some of them. So the first one that I would like to highlight is number 1, actually the congruence between healthcare system, mission, vision, and values, and patient-centered care, because we cannot, it's much harder to practice patient-centered care in an environment, in a work environment, in an institution that is not supportive of those values for patient care. So care is collaborative, coordinated. Care focuses on, very important, number 3, physical comfort as well as emotional well-being. And that takes many manifestations. I've been a patient myself recently, and invariably, whenever I go to see my specialist, someone comes in the room, maybe a resident, maybe a nurse, maybe a scribe, that doesn't introduce themselves. They just show up. So being who I am, I said to them, and who are you? Try to be lighthearted, but I want to convey to them that's a small gesture, small um, practice that can convey safety to patients. I'm a physician. I'm used to. I can understand, but not everybody. So it's a good reminder that emotional safety and well-being is very important. And number 4, cultural humility, if you will, very important. Uh, the inclusion of patients and families and their families is very pretty much part of what ideal patient-centered care is. And the presence of family members in the care setting is encouraged and facilitated. Today, I saw a new patient resident in our system for the first time, and I went to greet them, and they were with a partner, a romantic partner. Obviously, they were hugging, and so they both got up from the chair, and they wanted to greet me and motion towards, can I come in? So both of them, and so with politeness, I said, well, I would prefer if I see the patient first, and then we'll make sure to have time. And we did. Towards the end, we invited the partner, and we had a conversation, the 3 of us. And when the patient came in, this resident, I explained to them why I prefer to see them first by themselves. And I said, I cannot tell you the number of times that patients have disclosed intimate details that they haven't communicated to their partner. So I think it's best most patients understand. So anyway, presence of family members and information is shared in a timely manner so patients and family members can make informed decisions. Now, why are we talking about this? Is because study after study consistently have shown that positive relationship between patient-centered care processes and patient satisfaction and well-being. And this is an example from a recent systematic review of the literature. Now, to close this first step on the pyramid of trauma-informed care, another quote, it's too bad patient-centered care is not rocket science, because if it was, we would be really good at it. I was looking for a quote for this presentation on patient-centered care, and I came across this, and I had to take a double take on this because I was like, what does it mean? So I leave it hanging there because I liked it. This this kind of tongue-in-cheek, I don't know how to say it, but I think it's honors the difficulty, something that sounds very easy and intuitive that is so darn hard to actually do. But with that, let's move to the next step in the TIC pyramid, understanding the health effects of trauma. So here is, I don't presume to know how familiar you are with this literature, but it's huge. And so I chose just one slide to summarize something that can be relevant and true to many health conditions. So this is taken from a paper in a review, and on the right side of the figure, you see incident cardiovascular disease. So think about many other non-communicable medical conditions that can be put into place, and the dynamics, the mechanism linking trauma exposure to the disease is basically the same. And the critical components of this is a dysregulation of the HPA axis and the autonomic nervous system that translates into a number of physiological processes down to the intracellular phenomena such as oxidative stress and mitochondrial dysfunction that eventuates into an accelerated biological aging. And that is then creates inflammation and a number of other things that eventuate, in this case, on cardiovascular disease. So we're not going to do this in this particular presentation. It's a huge topic, but I think it's important to take it upon ourselves to understand better the health effects of trauma. Now, a little bit of a pivot here. Here we have understanding the health effects of stress. And on purpose, I'm using stress in not trauma, because this is another publication looking at the associations with early life poverty. So early life poverty, exposure to poverty, results in impact in the child biology. So we have this activation of the physiological stress response, fight or flight response, changes in brain structure and function, epigenetic phenomena, changes in the microbiome, and resulting immune responses and inflammation. Fast forward in life, this impacts child health and developmental outcomes, going from schooling and to behavioral problems, troubles with the law, you name it, and those translate in long-term implications for adult health and well-being. So we know this. So what do you notice here? How there's a, let me see if I can do this. The same mechanism going from trauma exposure to incident cardiovascular disease, we can think of chronic stress that can affect, like poverty, can affect health in the child and the adult, health and development. Wow, that's a huge issue. But now, what about stress? Is stress positive? Of course, stress and tolerable and positive stress can lead really to flourishing when it's not toxic. So toxic stress is a concept put forward first by the American Academy of Pediatrics to distinguish when an adult or adults and resources for those adults are present in the life of a child, the child can tolerate or derive positive outcomes from stress, as opposed to when there is an absence, like in poverty, there's an absence of resources, and there's very often other issues that prevent the presence of adults can buffer that stress and give meaning and help the child not only cope and survive that stressful situation, but also overcome it and flourish and thrive. So then you will ask me, so what is trauma? Is poverty trauma? So this is a slide from another review in which you can see trauma represented as a set of interaction circles or spheres of different domains, individual, interpersonal, and collective, or social, or structural. And so you have these levels, and you can start to think, my goodness, there's so many things that can affect our patients and ourselves that can translate in this trauma response, for lack of a better word. And so we need to be cognizant that trauma is omnipresent, is highly prevalent, depending on how you define it, and has consequences in the health of all of us. So now that we talked about poverty as a type of trauma, if you will, having health consequences, measurable consequences in development and health, others have proposed this adding to the adverse childhood experiences tree, this ACEs, the tree of ACEs, the roots like poverty, community disruption, lack of opportunity, economic mobility, social capital. So those structural and social conditions that are associated or lead to adverse childhood experiences as a root cause, like an upstream cause, a root cause, in other words, of ACEs. So we need to consider that too. So when we look back on the model of Sheila Raja of trauma-informed care, we could add this another stage or step in the ladder in this pyramid when we consider social and structural determinants of health, because they compound what we've been talking about, trauma, and should inform our approach to trauma-informed care. So let's go to the second learning objective. So we close the trauma universal precautions with 2 steps: understanding the health effects and patient-centered care. Now, asking while minimizing harm. So this should be highly applicable, hopefully, to your practice. And this is the result of my experience teaching for over 20 years this topic, and facing the challenge of being a psychiatrist, teaching medical students and colleagues of all expertises and specialties, saying, Dr. Sciolla, you're not going to tell me that I want to ask about ACEs in the emergency room. And so I take all those challenges into consideration. So I present to you an approach that you can, so you have now the approach of not knowing all the modifications you can have to your care that will minimize retraumatization without asking. But now let's ask. Let's move to ask, but in a way that is time effective, but gives you important information. So I want to ask you about an important issue in people's health, but today we don't have time to go into it in detail. If we decide it's important, I'll make sure that we have enough time to discuss this next time we meet. So this is one example, and this you can adapt to your own practice and style and accent if you have like mine. So it's just an example. So from one to now that this is an introduction, you're orienting the patient, which is something very patient-centered. Before you do something to the patient or you ask, you tell them why you're going to ask and why you want to do what you want to do. So from 1 to 10, 1 being not stressful at all and 10 being very stressful. How stressful was your childhood? Let's suppose a case, low score, I say 1 or 2, and you said, thank you, that's helpful for me to know. And you can move on. Now, what about from 1 to 10 being 1 being not stressful at all, etc. And the patient said, oh, I would say 4 or 5. Suggested response, thank you, that's helpful for me to know. Now, on a similar scale, 1 being not dysfunctional at all and 10 being very dysfunctional. How dysfunctional was your family or the environment you grew up in? Patient, I would say 8 or 9. So let me explain, based on my experience, sometimes when we ask patients about stressful, they are thinking of like what we call in the field big T trauma, not little t trauma, not things that happen maybe at school or in the neighborhood or within the family, but they were subtle. They're so chronic and little and small, if you will, but cumulative effect like dysfunction, that it's, unless you capture that with some measure, you lose that information. So in this case, patient says, I would say 8 or 9. And so you say, I'm sorry to hear that. That's okay. If it's okay with you, we can move on with our visit today. And then you can file that in your chart or in your mind and say, last time you told me about dysfunction in your household growing up. Can you tell me more about it? Because it's important for me to understand better when we have, now that we have time, something like that. Now, what about a high score case? So another tool, communication tool that I suggest to you from 1 to 10, etc. And patient says, oh, it was awful, 10 or 11. This has happened to me many times. Patient would say exactly that, or more even. So provider, I'm sorry to hear that. Now, a follow-up question. how much of that stress growing up is still affecting you as far as you can tell? A little bit, a lot, or not at all? And so patients will tell you everything. They will say, oh, a little bit, now I'm much better. There was a time in which it was terrible. Or they may say, well, after I went through therapy or whatever, it's not affecting me at all. Or they may say, I don't know. But anyway, so in case that someone who says a lot, you can say, I'm sorry, that must be hard. As I said, we don't have time today to honor the importance of this information. Are you okay with waiting to tell me more until the next time we meet? So again, asking permission, orienting the patient, explaining why, and so to maintain rapport and orienting the patient to and doing collaborative work. So another recommendation, regardless of trauma history, building on strength, and especially valuable when you have patients who have told you, oh, it's terrible, and you say, feel terrible, we cannot go into detail right now, but I know that this is affecting you tremendously. So let me tell you, you say to the patient, research has shown that people can deal with successfully and even thrive under tremendous adversity. I'd like to ask you this question to all my patients so I can get to know them better. And any of these could help. What is your life goal? So you are eliciting something positive of patients, something hopeful. What are your strengths? What are you good at? In this case of this resident I was telling you that I saw today for the first time, I asked this question, and there was a nice response because, well, so many of us, I mean, I'm not trying to flatter myself, but many of us physicians have many qualities. It's not too hard to find qualities. And then when the spouse came in, I asked them the same question, and it's a beautiful coincidence of the qualities. So that was a nice way to close the encounter. What is the most important to you in your life? What gives you meaning? Another way of asking the same could be spirituality, sports, I don't know, coaching soccer for my daughter. No. What helps you go on when things get tough? What has worked in the past? And doesn't need to be too, it can last, I mean, this can be gathered, this information, I don't know, 20, 30 seconds, and you can move on. So now we have reached an intermission in our presentation, and I want to really ask for audience participation using the chat function, and Brandon will be helping me to hear what you, any thoughts you have, questions, reactions thus far.
All right, we're waiting for people to throw their thoughts into the chat here. So far, we don't have anything.
And so, you know, no pressure. I will not move on unless someone says something. Sorry. I need your input, really. Otherwise, I don't think it's going to be as helpful as it could be.
So Dr. William Auch says, what percentage of patients have a high ACE number, and what is the most common cause?
Thank you for the question. So it depends. We have quite a bit of data on that. It depends tremendously on the setting. So probably the highest prevalences are, and this is kind of not rocket science, it's intuitive, but research has proven that, is emergency rooms, primary care, and location, underserved communities. Inner city, people of color are highly represented in those settings. They have a much higher prevalence of high scores of ACEs. And I'm sorry, can you repeat the question? Because I think there's a second element to that.
Yeah, what percentage of patients have a high ACE number, and what is the most common cause?
Yeah, thank you. The most common cause is emotional abuse. This is, again, a big generalization across settings, like an average is the most commonly cited. Um, but yes, so and things change a little bit over time. Like, for example, had we asked about divorce, which is one of the common questions for ACEs in the 50s, say, it would be different than asking the 80s or now, when the divorce and separation is much higher prevalence. So there's some fluctuation, historical fluctuations, if you will. Now, there's also uh, we are much, as a society, much more willing to talk about bullying, to talk about sexual abuse. And so those reports have gone up over time. But we don't know exactly how much is that is actual prevalence as opposed to facilitation of reporting those and voicing those ACEs.
All right, we have a handful of other questions that have come in.
Thank you. Great.
Yeah, this one is from Dr. Michelle Alley. What is the best way to support providers who are tentative in ACEs screening because it triggers their own history?
Ooh, Dr. Ali, thank you for that question. One of my topics of how can if I can elaborate a little bit. I don't know how much you guys know. Sorry for the guys. I'm speaking using guys generically. I hope that women and other gender identities in the audience don't feel offended by that um, generic term. So we know now, we have fairly good data, including our own data at UC Davis, of the high prevalence, should I say, the similar prevalence of ACEs among physicians, similar to the community standards. We're not lower, for sure. Importantly, though, as medicine has increasingly diversified, having more people of color, students of color, and physicians of color, and women, the prevalence is going up higher. And so, to give you one example, on one published paper that we had of medical students, third-year medical students, there was 12% that had 4 or more ACEs, and there was one medical student. This was anonymous, so we don't have no idea other than gender of the students if our sample had 9 ACEs. And so imagine to go through life and college and medical school and moving forward with an ACEs of 9, and all the students that had 4 or more, in this case at least, were female medical students. So to give an idea, we have also unpublished observations now in nursing school and veterinary medicine and medical school, fresh data. And this, so it's a real, Dr. Ali, I thank you for the question, because it's a real important issue. Some of us are exposed to trauma and ACEs. And so how to support, I think education is so important, because education can empower us. And let me give you one example. Educating ourselves about the science of ACEs gives us an idea that something happened to me that was beyond my control, that forced me to adapt behaviorally, cognitively, and physiologically without my permission. So, for example, I tend to react to loud noises, whatever, something. I cannot help with that. So people can, providers, physicians, nurses, whoever, can put themselves on the side, if you will, make a mental operation of saying, this happened to me. Now, that's not all of me. So I have now to learn to know that I'm an okay person or a good person or the person I want to be, with this legacy, if you will, that can be psychological, behavioral, a combination of things, or health, and I need to manage that. But there's a way to do that. I'm a firm believer of trauma-informed therapy. Psychotherapy in good hands can be enormously effective and helpful. But not only that, there are other forms, many other forms that lead to self-awareness. Anything, any practice that allow us to become more self-aware of our unconscious biases, if you will, are helpful. There's also practices that don't necessarily lead to self-awareness, but help with self-regulation and with this balance between overactive stress response system and an underactive, if you will, counterbalancing of that. So aerobic exercise or yoga, there's a number of other activities that can help us regulate. So science, education, I think is very important. And then tools to deal with when we feel triggered. How can we deal with, do we do self-disclosure or not? Do I tell my patients about my own ACEs or not? Do I need to do that? How do I um, uh, how do I am with patients? How I protect myself from being triggered? It's a huge topic, actually, because there's a neuroscience, again, help us understand the difference between, for lack of a better word, we can call empathy and compassion. Those are two, from a neuroscience perspective, two distinct phenomena. Empathy is at its core uh, a phenomenon that is involuntary to an extent, automatic, rapid. If any of you have read the book, which I recommend, Thinking Fast and Slow, it's an interesting explanation of how we have two brains in one slow brain and one rapid brain. So the quick brain, the irrational brain, the emotional brain reacts immediately. Emotional contagion is a very quick process that can happen. And so when we hear someone crying or suffering, we cannot avoid but to feel a reaction. Now, separate from that is compassion, which is something that doesn't come naturally to us necessarily. Some of us are more naturally predisposed to compassion. For others, it's hard work, but all of us can increase our compassion, which is a rational brain, slow brain activity in which we take perspective and we realize that we don't, for example, that we're helpless, that we cannot offer anything to this patient, and that would nothing concrete, and what we can offer this patient, for example, is hope or commitment. I'm going to be with you all the way through this process. I'm going to help you die, for example, something as radical as that. So compassion is reading the mind of someone and giving them what they need, what not necessarily what our instinct tell us to do. And every good enough parent would know this with children, because we are our best as parents when we give our children, what they need, not necessarily what they want. So that's a way of looking at those activities, compassion and empathy. So in allowing physicians who have a history of ACEs to develop that ability to act compassionately and protect themselves, set boundaries, and not get swallowed, if you will, by this need to rescue and help and fix everything, it can be very helpful. I hope that helped with the question. Thank you again. What other questions do we have?
We have more than we have time for. Do you mind
Oh,
if I send a few to you? And you can
Yes,
answer them via email, but if you want to do
sure.
one more, we've got a really practical one here from Dr. Lily
Okay.
DiGiacomo.
Yes, please. Let's do one more.
All right. What do you do when you ask to wait until next time to discuss more, and perhaps the patient feels abandoned by that?
Yeah, it can happen. So, let me answer that. As a psychiatrist, I guess there's no other way I can say this, but we all know this. What I want to say is something that is commonsensical, but it's hard to practice. We all know this. We cannot control how other people feel or think. Well, we would like to be able to, and to some extent we can sometimes. We can manipulate, we can influence, we can persuade, but by and large, we cannot help our patients feel what they will feel, including negative feelings. And so now, in a trauma-informed care perspective, when you have behind you, so to speak, supporting you as a individual provider, a team, a system, an institution that is trauma-informed, hopefully the harm would be minimized in the long term, because patients in the long term would understand that that was a moment in which they felt abandoned, but you didn't mean to abandon them. So so that's one answer. It might appear callous on my part, but sometimes it's the only thing that we have time for, like saying, like just moving on with our lives and hoping for the next time to be able to, uh, if that has been experienced by the patient, it will come up. And for example, we can start by saying, so how did it feel like sharing with me what you share about your childhood? And the patient, if they have been seriously felt abandoned, they will tell you, and then you can address that. Now, another way to that occurs to me that could be helpful is when you notice the patient and that the patient is distraught or upset. And so you can say, verbalize, I can see that this is not easy for you, that you're upset. I'm sorry that we don't have time to address this, because hopefully, parentheses, you already elicited a chief complaint or the reason why the patient is coming to see you. And I want to honor what you told me at the beginning, that you wanted to establish care or follow up on your diabetes, whatever it is. So again, there's not a perfect way out of a situation like that, but there's I think two kinds of responses. One, when you cannot say anything because you're just pulled away from the encounter, or because you don't notice the patient is upset, or when obviously the patient is starting to tear up, for example, and you say, I'm so sorry, this is hard, but we cannot honor that. We'll talk about this next time. So shall we move on? Something like that. All right, so I know that we have more questions and I will work on those, and I so much appreciate those. But we have a third learning objective that depends heavily on you now. So I'm turning this back onto you to make it even more relevant and leave you with something like a homework, if you will. So we don't need to, we're not going to solve things, but my hope is that you will start thinking about this topic of changing policies and practices. So, question to you all: can you think of a policy or practice in your workplace that should be modified to minimize the risk of re-traumatization? Maybe now you work in a very trauma-informed place and there's nothing. Great. But even if it cannot be modified right now, at least you will increase your awareness of something. This is something that we need to fix. This is a problem. And what about a policy or practice that can be modified to minimize the risk of re-traumatization? Another question, I'm interested in all the answer to any of these, any or all. How does doing nothing align with your organization's missions and values? So what this question is trying to get at is increased motivation for change, because maybe there's a dissonance between what your institution's saying that they want to do and their values and what's actually happening, and nobody wants to do anything about it. So I'm going to shut up now and ask Brandon to convey to me any responses to these questions.
Right. Dr. Maynard Johnston says the damage to children who are exposed to domestic violence is grossly underappreciated. Children don't even have to see the violence to be affected. As you pointed out, most people are unaware of the damage that ACEs does, even professionals. Um, Dr. Alley added, absolutely, sexual abuse is more common than people realize as well.
So thank you. But the question is to you guys, again, my guys, sorry, to you audience, dear colleagues, what can you think of something that should be modified? How, I guess I'm taking this step further. So for example, the ignoring the prevalence of childhood sexual abuse or the consequences to children exposed to household violence. So what can you think of a way to minimize retraumatization? How would you change that? What would you change around that issue in your practice?
A moment to respond here.
Yes.
Dr. Brian Mackin says increasing the appointment time.
Yes, I completely agree with you. And that's, I guess, my comment would be, that's why it's so important to have on board leadership and institutions, because as a single provider, there's a limit of what we can do in terms of trauma-informed care. So yes, increase the time and think creatively around those barriers, because, for example, someone in your system can say, what about the bottom line, Dr. Sciolla? And I could say something like, yes, the bottom line, very important, but the bottom line this month versus the cumulative bottom line over 10 years to our institution in terms of overutilization of services, for example, of unnecessary surgeries, even, I mean, all kinds of things. So how can we have a more rational and nuanced conversation about the bottom line? So in the interest of time, I'm going to give you some examples of things to say, to modify in our business as usual, if you will, that other people have thought and come up with. What can I do to make you more comfortable during the procedure or examination today? Simple, just that. So instead of us coming up, because we don't know how many things we could be overwhelming, ask patients, what can I do to make more comfortable? Just to let you know, this is generally how this type of appointment runs. First, blah, blah, blah. This is what happened with the resident today, fresh on my mind. We sat down and said, the first thing I said, well, let me tell you how this, I would like us to go this encounter. And because I don't know whether you've been to a psychiatrist before, and they said immediately, no, I've never been to. So that was helpful. Another example, so you know what to expect. What we would normally do for this type of appointment is first to this, then what have you, etc. So these are examples. Now, other examples of modifications that other people have thought about for safe environment, physical and emotional. And these are all things that I think that are commonsensical, and I'm not going to tarry too much on this. But for example, in the bottom line, the bottom bullet point, making sure patients have clear access to the door in exam room. Let me tell you a recent example. Just last week, a resident and I saw together a former, not former, it's an active police officer with severe PTSD, and a male in his 40s. And one of the first things that we sat down, I said, how does this feel? And this police officer is in a medical leave because of the PTSD, was sitting back to the wall. We were the opposite end, and the door was next to him. And he said, this is perfect. This is the way I like it, next to the door. And actually, it was very evident at some point they were ready to bolt. So something as simple, quote unquote, as making sure that they feel comfortable in the space. Excuse me. Another important, I believe, is consistency in schedules and procedure, explaining office offering sufficient notice and preparation when changes are necessary. So often, just today, another patient I saw, an older adult, female adult, feeling so positive with a new specialist that they have met that gave her hope, only to be told later by a staff member that they will no longer follow up with her, when this wonderful physician that she really liked didn't say anything. Oh, by the way, I won't be able to see you. I mean, that happens all the time. And this patient happens to have huge issues with emotional neglect, abuse. And so that was very hard on her. So in closing, this is the last slide before we open up for questions too. Very important resource, I believe, and I don't know how many of you are aware of this. So there's a wonderful Canadian Public Health Association brochure with lots of information and suggestion. Supported, one of the co-authors is a pioneer in trauma-informed physical exam. Ask permission before proceeding. Provide instruction using easy to understand professional language. Something as simple as, I will now inspect the penis for any ulcers, as opposed to, now I want to look at your penis. That, only imagine what it can be for a survivor of sexual abuse, for example. That change in language, how much less threatening and personal and triggering could be. So utilize appropriate nonverbal skills, avoid the phrase for me, so common that we say, lower your pants for me, or things like that, for me. Language even can have sexual connotation unintendedly, like using exam table versus bed, now laid on the bed. So remain mindful of draping, patient modesty and comfort throughout the examination. And this, I like this because it's an invitation for us to be, in all this trauma-informed, flexible, patient-centered, and be humble in a way, because, well, I am a control freak, and many of us are very controlling because we're anxious. We want to do a good job. We look excellence. And so relinquishing control is not easy. To be open to new methods and patient assistance, like patients hand over the examiners, self-insertion of specula or swabs, foregoing not using stirrups. Those are just examples. So on that note, we have, I think, a few minutes for questions, and my sincere thanks for allowing me to talk with you tonight about this topic.
We can jump back up to the questions that we didn't have an opportunity to get to earlier, if you'd like.
And actually, can I stop sharing? I think it's, I don't think it serves a purpose right now. I cannot see you all, but I know that you're there. So what questions do you have?
Dr. Emmanuel McCauley asked, how do you overcome patient reluctance to share what may be difficult or traumatic events?
Say that again. I'm sorry. I lost misheard the last part of the question.
How do you overcome patient reluctance to share what may be difficult or traumatic events?
Oh, yeah. Well, again, patient-centeredness is the answer, meaning that uh, we can only do so much, and a patient doesn't want to disclose, even if we know that this is very important and that can be critical to help them. We have to wait until they are ready to disclose. I don't know how to else to tell you how complex is the process of coming to terms with something that has happened to us that is hard to share with other people. Even if rationally we may know that is the right thing to do. So I think conveying acceptance goes a long way to say, it's okay, I understand. I can accept that it's just too much for you to share with me, and follow something like, I hope that at some point you will be telling me. Let me give an example. From my own practice, some years ago, I was a Mexican-American man in his 40s came, referred from a primary care physician saying, I was diagnosed with fibromyalgia and panic attacks, and I'm depressed, and I cannot work because my back, obesity, multiple problems, a young man. So quickly, he disclosed a bunch of ACEs. He terrible grew up in Mexico, immigrated, terrible childhood, including the death of his mother by cancer when he was 2 years old. So given the fact that he was willingly sharing this and wasn't saying anything about sexual trauma, if you will, I said, what about any sexual experience that were not good for you? And he said, I don't want to talk about it. Yes, but I don't want to talk about it. So what I said to him is something that I share with you too, that you can ask in those situations. I ask, I can accept that. I accept that, but can you tell me, without telling me what you don't want to tell me, how would you feel if you were to tell me or talk about it? And he said, I would die of shame. I would never forget those words. And I knew enough. I didn't know what needed to know more than that something of sexual nature had happened in his childhood that he was deeply ashamed of. So I said, thank you. And I hope at some point in the future, once you trust me enough, you're able to tell me more about that, because I can tell that is affecting you to this day. Does that answer the question? Hopefully it does.
And unfortunately, that's all we have time for today. So I want to thank Dr. Sciolla for taking the time to speak with us this evening. And I want to remind everyone that you'll be getting an email with a link to a survey that you'll get your CME at the end of it. Again, it's worth 1 CME. And any last words, Dr. Sciolla?
Just send me emails. My email is there. Any questions, lingering issues, please. I welcome that from you, feedback of any kind. Yes, thank you.
All right, thank you. And good evening, everyone.
Good night, yes, everyone. Have a good evening.